Good evening all. So today's class will be about arterial pulse. So this topic is such that it's a topic must know, but not as much as in use in the present era of echocardiography and all, wherein the clinician, we can just by doing an echo, we can diagnose whatever we used to do with an arterial pulse. So but for your external exam, this is must, and in your entrance exam also still questions are being asked from this. So a very important topic. It is such a basic topic that if you don't answer anything, or if you fail to do what examination, like fail to demonstrate it, you might end up failing it. So an equally important topic as well. So highly important topic, but in the current era, not that much in use. So, and yeah, since because of that, searching for this information was also equally tough. Like any book we go to, hardly one page will be, any recent edition we go to, hardly one page will be given about this topic. So, okay, with that in mind, and since this topic, it is more of me telling you stuff, couldn't include any cases and all, because like it is what you see in examination. So couldn't put any cases for this topic. And if we start discussing about each case in detail, time will be a problem, because this topic is a bit huge. Too much theory has been there. So since this topic is very important, kindly bear with me. Might be a bit dry, and but then yeah, I've tried to make it interesting. And yeah, if you guys are not able to understand all these terms like pressure, volume, any Bernoulli's effect, all those physics concepts, it's okay. If you don't know that also, it is okay. It has just been put over here for the sake of understanding. Okay, so let's start this. So how we deal with the topic: introduction, how we examine the pulse, then coming to physiology, and finally the components of examination. So what component of pulse, what we feel usually, what is the component of pulse that is felt among these options given, A, B, and C? What is the component which you actually feel for? Yeah, good. So all of you are aware of it. It is the pressure wave what you look for. Good. Okay. So let's start. Introduction. So this is the very famous statement that the arterial pulse has been called the mirror or index of the heart. And why do we call this? We'll further look into it. That is our topic for the day. And what is the definition? So the definition is, as you guys already mentioned, a pulse is the pressure wave. Pressure wave, not the column of blood or the blood ejected that you feel, but it is the pressure wave that is felt by the fingers, by the tip of the fingers, okay, by the tip of the fingers, produced by the left ventricular systole, by mainly the contraction of the left ventricle. And the contraction of the left ventricle will start the pressure wave, and that pressure wave travels through the arterial tree into the peripheral direction. So that is what we see. So a pulse is a pressure wave that is felt by the fingers, by the tip of the fingers, produced by the left ventricular systole, contraction of the left ventricular systole, and traverses through the arterial tree in a peripheral direction. Okay, so this was the basic. So when the left ventricle contracts, so what do we see? Two things happen. One, a pressure wave is generated. Two, blood column, the stroke volume, whatever the stroke volume is there, the blood gets ejected. So both travel in the pulse. And so in the artery, what we see, both of them travel. But what happens is, when we look at the velocity of pressure wave is much faster. So what reaches periphery much faster for you to palpate? This one, because velocity is around 10 meter per second, but the blood column, the velocity of blood column is just 0.3 to 0.5 meter per second. So this arrives a bit late. So what you actually palpate for, or what you actually look for, is this, the pressure wave, which arrives faster. Okay, that is why pulse is the pressure wave. Very important concept, basic concept, that is. Okay, and this is the one that conducts much faster and palpated as pulse. So that is what we saw. Next, let's look into the method of examination. And This is very, very important. Like if you don't end up answering, hopefully this doesn't happen in your external exam, but in case like that day you're tensed or something went wrong and you're not able to answer anything, the examiner will finally come down to examination of pulse. And please make it a practice at least once, examine every pulses, all the pulse, not the radial and carotid, all the peripheral pulse. Know that, make sure that you've gone and examined in the patient and you know the right method. So I'll just elicit the right method over here. I can't elicit, I'll tell the right method, but go back and elicit in the patients, okay? Because this is the most basic thing to know. So for rate and rhythm, which is the best pulse, rate and rhythm, and for character and volume, where do you go for? Yes, good. This is radial. This is carotid. So, but that doesn't mean that you stick to only this. All the peripheral pulses have to be seen. And one more thing, measure both the pulses, both left and right side, and look for if there is any difference present. Okay, that is also important. And how do we measure? With the three fingers, index finger, middle, and the ring finger. With the three fingers, slightly palpate over the anatomical region where you expect to feel the pulse. And one more thing, don't press it very hard. If you press it very hard, just because you're not getting it, it's just might be because there might be some small anatomical variation in that patient and you will not be getting the pulse, but on pressing harder you will end up feeling your own pulse. So one more thing, very important thing is slightly palpate over the expected area where you will find that pulse. So as a routine, it is necessary to measure all the peripheral pulses along with radial and carotid, okay, and measure both the sides. And all the pulses should be compared to that of opposite side. That is what I had mentioned. So what are the peripheral pulses? From down, if we come, first is the dorsalis pedis artery. So where do you expect to find it? It is usually lateral to the external hallucis longus tendon. So how do we get to know where this tendon is? If this is the great toe, you ask the patient to extend his great toe. Okay, when you ask the patient to extend his great toe, the external hallucis longus tendon becomes prominent. So, and again, one very important mistake made is at the proximal end of the first web space, we'll end up going and palpating somewhere in the middle or at the distal end of the web space. That shouldn't be done. At the proximal end of the first web space, lateral to the external hallucis longus tendon, go and palpate against the bony prominence, navicular and middle cuneiform bone, go and palpate, okay, with the great toe dorsiflex. It might be absent in around 10% of the cases. If there is confusion existing, then go palpate the radial artery simultaneously, okay. Do not press the artery very hard. You might palpate your own pulse. That's why palpate it softly, and then still confusion exists, go compare it with your radial pulse, okay, of the patient. So this is how to elicit. Greater toe is extended, great toe is extended. So this is the external hallucis longus tendon. Lateral to it in the first web space. In the first web space, proximal, you go and measure. Okay, this is important. Next is anterior tibial. Next is anterior tibial. So where do you look for anterior tibial? One is between the lateral and medial malleolus, lateral to the tibialis anterior tendon. This also you just dorsiflex the foot so that the muscles are relaxed. Once you dorsiflex the foot, medial and lateral malleolus in between measure with the three fingers, okay. So dorsiflexion is important because you will end up relaxing the muscle. So in case if you're not able to feel it on dorsiflexing, you'll be able to feel. So that is what is mentioned anteriorly above and midway between the two malleoli against the lower end of tibia, lateral to tibialis anterior with patient foot in dorsiflexion. So the same thing is shown. See over here, foot is dorsiflexed in between the lateral and medial malleoli. In between, you measure with the three fingers. Next is posterior tibial artery. Posterior tibial artery is felt where you go, it's felt over the calcaneum in between the medial malleolus and tendon of Achilles. So midway between the, over the calcaneum, midway between the medial malleolus and the tendon of Achilles. So if this is the medial malleolus and tendon of Achilles, midway you go and feel for it. So That is what is done over here. Again, if you dorsiflex, it might be a bit easier. Palpation of the posterior tibial artery, midway between the medial malleolus and the tendon of Achilles. Go and feel for it. Next is popliteal artery. Popliteal artery, it is as such, it is very difficult to get. So because it is deep in it. So there are two methods. One, with the patient supine, you just make him flex the knee around 30 to 40 degree, get behind the patient, get behind the patient's limb, and just try to palpate, just try to move your fingers. Okay, move your fingers in the lower border, in the lower end of the popliteal fossa. So don't go and do it off in the above, because the artery runs very much deeper over there. So in the lower border against the tibial condyle, go and feel for it. Okay, move your fingers, you might get the pulsation. One more thing is, put the patient in prone position, make him bend over 90 degree. Again, at the lower end of the popliteal fossa, try to palpate. Okay, so that is what is mentioned. The knee is flexed by around 40 degree with the heel resting on the bed. Again, this will relax the muscles. Place the finger over the lower part of the popliteal fossa, and fingers are moved sideways to feel for the pulsations against the posterior tibial condyles. Posterior tibial condyles, don't go and do it off above. You will not find it. With patient in prone position, knee is flexed to 90 degree and feel for the artery in the lower popliteal fossa. Same thing being demonstrated. Okay, over here 30 to 40 degree flexion in the lower popliteal fossa, over here 90 degree. Okay, this is supine, this is prone. Next is femoral artery. Femoral artery, what do we do? This in the groin, midway between the anterior superior iliac spine and the pubic tubercle, midway between the inguinal ligament runs. Right below it, over here, you go and feel for it. Okay, and best position to keep is slightly abduct the foot with external rotation. External rotations with slight abduction will give better way to palpate it. Okay, so that is being mentioned. This is felt in the groin, just below the inguinal ligament, midway between anterior superior iliac spine and pubic symphysis, with the hip flexed for about 10 to 15 degrees with abduction and external rotation. So next is radial artery. Radial artery, this is the simple thing which we measure: slightly pronate, semi-pronated, and semi-flexed, and take. Semi-pronate the hand, semi-flex it, and then measure. Okay, and then look for it. Look for both the left and right, and look for any delay, or if it is present or absent. And rate and rhythm is best measured in the radial artery. So that is what is mentioned, with patient's forearm slightly pronated and wrist somewhat flexed, felt just above the wrist on the lateral aspect against the lower end of the front of the wrist. Ulnar artery, right opposite. If you go at the lateral side, this is in the medial side. So that's the only difference. Next is the brachial artery. So brachial artery, you can either measure with 3 fingers or the thumb. You can either use thumb or 3 fingers. Elbow should be flexed again to relax the muscles, and medial to the biceps tendon, feel for it. Medial to the biceps tendon, feel for it. Okay, with the opposite hand. If you're using the left, measure with the right. With mostly thumb is better, or if not thumb, with the 3 fingers. So as mentioned over here, with flexed thumb, medial side, medium to the tendon. Okay, so with the elbow flexed is felt in the front of elbow, just medial to the tendon of biceps, with thumbs or fingers. So what is important is thickening of the arterial wall and visible pulsations are made out better over here than radial artery. If you're not able to make out in radial artery, then come back and do it over here, because it is better felt in the brachial artery. And to measure the character of the pulse, like for some reason you're not able to palpate over the carotids, next best site is brachial artery. Okay, important to remember. Next, coming to axillary artery. So where is this felt? Felt on the lateral aspect of the axilla against the upper end of the shaft and neck of the humerus. So at the lateral end of the axilla, so this is the axilla over the lateral end at the upper border. Okay, we go and feel for it. As seen over here in this position, make the hand lie over you and go and feel for it. Okay, next is subclavian artery. Subclavian artery, it is easy to palpate just above the middle of the clavicle, just above the middle of the clavicle in the supraclavicular fossa, and make the patient to lift the shoulder this way so that it becomes easier. The deep fascia will get relaxed. So make the patient to lift like this, go behind the patient and just palpate over here, middle of the clavicle in the supraclavicular fossa, as shown over here. It is shown over here. Next is carotid. Carotid, how is it felt? It is felt in the carotid triangle, medial to the sternocleidomastoid muscle, medial to the sternocleidomastoid muscle against the carotid tubercle of the transverse process of sixth cervical vertebra. What is this called? What is this tubercle also called? Anyone? Kessagins tubercle. Okay, good, good. So this is the tubercle's name. Okay. So slightly turn the neck to the opposite side, medial to the sternocleidomastoid muscle. You can measure with the 3 fingers. Okay. And again, character and volume is best measured over here. Character and volume is best measured over here. Next is superficial temporal artery next to the tragus. Next, right, just next to the tragus over the zygomatic bone. Go and measure. Okay. So this was about method of examination of all the peripheral arteries along with the central arteries like carotid. Okay, carotid, subclavian and all. So that was very important. Now let's look into some amount of physiology as to how the arterial waveform is formed. So these are the 2 comparisons. This was by putting a catheter inside the ascending aorta, a catheter was placed, and this at the carotid artery, gauge was placed, a gauge manometer was placed to measure, and we see that waveform is almost the same. So that's why we go and look into the carotids for the character of the wave. So next, the activity is recorded is due to change in the wall tension. So initially what we learned was it is the pressure wave that is being recorded. So what is this pressure wave that is recorded? How is this pressure generated? It is because of change in the tension of the blood vessel. So when we palpate, what we actually find is change in the tension, wall tension. Okay. And so how does this change come about in the tension of the wall? One is because of change in the amplitude, because of the pressure wave that is generated by the contraction of the left ventricle. Next one is because of the change in the diameter that is caused because of the flow of the blood. It causes change in the diameter, correct? No? And one more is because of the pressure wave that is being transmitted. So it's both these components put together is the change in the wall tension that we get when you go and measure the arterial waveform. So this is governed by what is called as Laplace law. So this is the basic, it's governed by the Laplace law. So what does this Laplace law state? That the tension which we measure, arterial waveform, using the pressure gauge which we measure is directly proportional to the pressure, directly proportional to the radius, and indirectly proportional to the thickness of the vessel. So in case of a hypertensive or in case there is atherosclerosis that has taken place, thickness of the blood vessel increases. So what happens? Tension decreases. So on palpating, you will be able to find a thready pulse. You will not be able to make out the pulse. So in the similar way, if the stroke volume is large, what happens? Radius of the vessel will expand. So there will be more expansion. So you'll get to find a bounding pulse because the wall tension is increased. So in the same way, pressure also. If stroke volume is large, as in case of aortic regurgitation, what happens? Again, pressure generated because of stalling force, left ventricle contracts vigorously. In that case, what happens? Again, the tension developed will be high because of the pressure. So it is directly proportional to the pressure, directly proportional to the radius, and indirectly proportional to the thickness of the vessel. So let's look into each of the component. First one is pressure. How is this pressure generated? It is generated by the contraction of the left ventricle. Okay. One is it is developed by the contraction of the left ventricle. This happens during systole. Okay. During systole. But what we see that in the waveform recorded, there is a diastolic component also. There is a diastolic component also. Correct? No? So how is this formed? Diastolic component is because of the reflected wave. And how is this generated? This generates pressure wave, contraction of left ventricle. It generates a pressure wave. So this pressure wave which travels, it is not an open system. It is a closed system. No, it goes, hits the periphery and comes back. So at every branching point, it goes, hits and gets reflected. So this reflected wave, this reflected component is what we get in the diastole. So the diastolic activity which you see is because of this reflected wave. So the pressure pulse generated by the left ventricular contraction gets reflected back as reflected wave. So this was to do with the pressure component. Next is radius. How is radius getting affected? It is because of the volume of the blood that is received by each segment of the artery, which causes change in the radius. This change in the radius will cause change in the tension. Okay. So as a whole, all these things will contribute to the contour of the pulse. Contour of the pulse. So this is what we see when we compare it with the phonocardiogram. This is S1. This is S2. Between S1 and S2, we have the systole. After that, we have the diastole. Okay. So in the first systole, we'll have two peaks. One is because of percussion wave. Second one is tidal wave. And you have a notch over here, which is called as anacrotic notch. Anacrotic notch. This is followed by a diastolic wave. This is followed by a diastolic wave separated by one more notch called as dicrotic notch. Correct? No? So what is this percussion wave due to? What is this tidal wave due to? And what is this dicrotic wave due to? Anyone with the answer? See, it is not. See, if you go and palpate, you just get one peak. Okay, if you go and palpate, now what we are talking about is one that is recorded by the pressure, the gauge which was kept over here. Okay, so when we palpate, it is just one thing which we feel. It is just one peak and gone. Okay, that is what we see on palpating. This is why putting a pressure gauge near the carotid, we measure. That is when you get this characteristic contour. Okay. So percussion wave transited, okay, good. Tidal is because of the volume, okay. Then it is because of peripheral vascular resistance. So good. All of you are aware of it. So let's see. During systole, you get two peaks. This is at the carotid, okay. This is at the carotid that you get two peaks. During systole, you get two peaks along with a notch called as anacrotic notch. So the first peak is because of percussion wave, okay. And this percussion wave is because, as mentioned earlier, it is the pressure wave that travels faster than the column of blood. So the first peak which you see is obviously because of the pressure wave that is generated by the left ventricular contraction. Correct? No? So that is which gets transmitted to the aorta and the carotids directly. So that is what you feel. Next comes the tidal wave. This tidal wave is this form. Then comes the column of blood that travels very slowly behind the percussion wave. This travels at around 10 meters per second and goes off into the periphery very fastly. Then comes the column of blood at around 0.3 to 0.5 meter per second. So that is what you get as the tidal wave. So that activity is the column of blood traveling following the pressure wave. This is the tidal wave. This tidal wave is because of that. Percussion wave is because of that. Then comes a dip in the pressure will be there. So once percussion wave, tidal wave passes, there is nothing left. So there will be dip in the pressure. And this usually coincides with S2. And this is called as incisura. Okay. After this comes the one more wave. This wave is the reflected wave that is coming back. Okay. So that again will cause one more peak called as dicrotic wave. So this is the reflected wave from the periphery. Okay. So again, the contour is best studied at the carotids. I've already mentioned. Why is that? Do you expect any change to take place from center to periphery? Anyone? What happens once we go from center to periphery? What happens? See, as already mentioned, anyone knows the answer, you can put it in the chat box. P wave becomes steeper. Okay, fine, good. So yeah, the contour of the wave changes. You won't have the same contour as seen in the carotids. You know why this happens is, one is because the column of the blood travels slower. So that will almost get eliminated. So only two components will come into the picture. One is the pressure wave that you see. One more is the reflected wave that you see. Correct? No? So you get just one upstroke in the systole and one upstroke in the diastole. And this is very much smooth. This is very much smooth. The incisura which was there is very much smooth. So why are these changes that taking place? One is, as told, it is dominated by the percussion wave and the reflection. Next one, we'll have a rapid upstroke. Rapid upstroke. Why? So this upstroke is measured by the compliance of the vessel. So the left ventricle that contracts sends the pressure wave. Once this pressure wave is sent, it depends on the compliance of the vessel as to whether to take the pressure or not. So the change in the pressure divided by the change in the time as measured in terms of compliance of the vessel should be seen. So as we move more peripherally, the walls become more and more stiff because of the increased peripheral resistance. So what happens in carotids? In carotids, it has enough elastin content. So it will expand and contract. It will expand and relax very nicely. So change in pressure divided by change in time will be good. So the compliance will be good. So you will find a nice smooth wave as a nice smooth percussion wave. But over here, what happens? Peripheral resistance is high. Vessel will become very stiff. In that case, what happens? We'll see a rapid upstroke. You won't see such smooth activity, nice activity, but you will see a rapid upstroke. So that is what we see over here, a rapid upstroke due to the stiffness in the vessel. This is followed by anacrotic notch, which was there, incisura, which was there. It becomes less prominent. Why does this happen? As the column of the blood travels much slower than the pressure. So one thing is because as already mentioned, pressure wave and the reflected wave dominates the activity. Over here, we were expecting a dip in the pressure because there was no activity taking place between the systole and diastole. But as we move to the periphery, the reflected wave comes in much faster because the branching points are closer. You're coming towards the end. So the reflected waves comes back much closer, much faster. So what happens? What happens is this dip in the pressure which we see will not exist. It will get replaced by a smoother notch, and the dichotic wave which is there comes back faster. Okay, that is why we see anacrotic notch becomes less apparent. Next is the incisura is replaced by smoother dichrotic notch. Okay, I gave the present reason which I gave was for this. Incisura gets replaced by smoother dichrotic notch. Sorry. Incisura gets replaced by smoother dichrotic notch because of the increased peripheral resistance and the wave coming back faster. This notch which was there over here becomes like this. Okay, this one is anacrotic notch becomes less apparent. Why? Because this notch which was there becomes less apparent because in the peripherally it is just dominated by the percussion wave and the reflected wave. Okay, that is the reason. Okay, so these are the changes which we expect. So what are the changes? One is the rapid upstroke. 2, anacrotic notch becomes less prominent. 3, incisura is replaced by smoother dichrotic notch. Why rapid upstroke? Because the compliance of the vessel decreases. So change in pressure by change in time, what we expect to happen in the aorta will not happen in the periphery. So in the aorta, since the elastin content is nice, there will be a smooth upstroke. And over here, there will be a rapid rise in the pressure because the artery wall becomes very much stiff. Next is anacrotic notch becomes less prominent because the activity is dominated only by the pressure wave and the reflected wave. 3, incisura is replaced by smoother dichrotic notch. Why? Because the peripheral resistance is good. So the reflected wave comes back much faster. So this will not take place. Okay. Yeah, T merged with P wave. Yeah, T wave will almost disappear. Okay, T wave will come very much later. So we can tell that T wave almost coincides with the reflected wave. Okay, so next let's see what are the factors affecting the pulse contour. What are the factors affecting? One is the incident pressure wave. Incident pressure wave is because of the left ventricular contraction. So what are we expected? What are the factors that affect? One is the compliance of the aorta. When the compliance is good, we'll expect a smooth raise. When it's raised stiff, a rapid upstroke we'll expect. Next is depends on the stroke volume. Good stroke volume will send out a good pressure. Next, and indirectly the stroke volume is dependent on the left ventricular pump activity. So these are the determining factors. Next is the pulse wave velocity, the velocity at which this pulse wave travels. Okay, before that we have the tidal wave. Tidal wave is again dependent on what? Since it is dependent on the column of blood, this also indirectly is dependent one on the stroke volume. Next again the stiffness of the arterial vessel. This also depends on the same two components. Okay. So pulse wave velocity and the velocity with which the pulse wave travels to the periphery depends on the pressure, mean arterial pressure. More the mean arterial pressure, more the mean arterial pressure, more stiff it becomes, so more faster the velocity travels. So as you reach the periphery, the pulse wave velocity increases. Okay. Next is based on the tone. Next is based on the tone and compliance. So, and the intensity of reflected wave, the reflected wave that comes back, that depends on the peripheral vascular resistance. So vasoconstriction and vasodilatation. If there is vasoconstriction, tone is good, so reflected wave is increased, intensity of reflected wave is increased, and the velocity also increases. If the tone is not that good, there will be vasodilatation, and the intensity with which it comes back will decrease. Now, so this much is enough. This much is enough for us. Next, we'll see how all these factors affects. How all these factors affects when we come to the pathology. Okay. So this was the basic physiology. Next, we'll move on to components of examination. So what all you'll examine for in a pulse? What are the important things you look for? So when you go for clinical examination, if you comment on the pulse, you cannot just say this is the rate of the pulse. No, correct? No. So you'll have to talk about other components also. Volume, rate, rhythm, character. Good. Rate, rhythm, volume, character. Anything else? Rate, rhythm, volume, character, condition of the wall, delay, pulse pressure, deficit. Good. Good. So you guys are aware of it. So you'll have to comment of all these things. Rate, rhythm, volume, character of the pulse, tension, equality or delay. Equality doesn't nothing much means any delay whether it is present, condition of the vessel wall, pulses paradoxes, and pulse deficit. So in these terms you look for. In these terms you'll have to comment about the pulse which you examine. So first thing is the rate. So normal rate, we all are very much aware of it, is between 60 to 100 beats per minute. So bradycardia is less than 60, tachycardia is greater than 100. In both there can be physiological causes as well as pathological causes. Physiological causes can be elderly due to SA nodal degeneration, or in case of athletes wherein there will be increased vagal tone in the athletes, or because of sleep, because of the decreased adrenergic drive. Pathological conditions, bradyarrhythmias can be there. Then like something like sick sinus syndrome, all those things, AV block. So then comes inferior wall MI. Why in case of inferior wall MI you'll get bradycardia? Very important question again. Inferior wall MI you will get bradycardia. Why? So you guys be typing the answer. Next comes non-serious causes like hypothyroidism. This will decrease the number of beta-1 receptors. Next, obstructive jaundice because of bile salts, that will go and decrease the SA nodal activity. Again, intracranial pressure, this is a component of Cushing's triad, you get it. Hypothermia decreases, and certain drugs like beta blockers, non-dihydropyridine, calcium channel blockers, digoxin, all those things decreases. Yeah, because the right coronary artery which is there, it supplies both the SA node as well as the inferior node wall. Good. Pawan got the answer. Next one is tachycardia. Tachycardia greater than 100 beats per minute. Okay. Again, physiological, pathological. Physiological in case of infants, in case of because of exercise and because of emotion. Infants, there will be decreased vagal tone, we could decrease vagal discharge, so that's why they'll have tachycardia. In fact, it is normal for them. For that particular age, the rate is normal. Then in case of exercise and in case of emotion like angry, anxiety and all, there will be decreased sympathetic discharge, which will cause the increase in the activity. Pathological, again, tachyarrhythmias like ventricular fibrillation, atrial, supraventricular, all those things, supraventricular arrhythmias. Then comes the ventricular arrhythmias, all those common causes. Anterior wall MI. Anterior wall MI, why? Why anterior wall MI causes tachycardia? Inferior wall MI causes bradycardia. You got to know the inferior wall. Anterior wall MI, this is mainly again because of, okay, you guys answer for that. Then increased cardiac output states obviously causes increase in the heart rate. Then comes hypovolemia, there will be stimulation which causes this. Drugs like atropine, beta agonists, calcium channel blockers, it will directly increase the activity. And hyperthermia, increases. Okay, as in case of due to the pain, anterior wall MI is near the thorax, the cavity, anterior wall MI, so it can thorax that is supplied by the sympathetic nervous system can get activated. Okay, so next is this very important question: variation with temperature. So what we expect is for every 1 degree Fahrenheit increase in temperature, heart rate must increase 10 beats per minute. So this is the normal, usual norm. But if this doesn't happen, then we call it as relative bradycardia, or what is called as Fidget's sign. So where all we expect, one is the infective causes, other one is non-infective causes. Infective causes is because of direct SA nodal depression. SA nodal activity is decreased. Okay, so this is the infective causes. So again, various. So the main ones which you have to remember is Salmonella typhi, then comes Legionella, Mycoplasma pneumonia, Rickettsia, then comes diphtheria, then comes yellow fever, dengue and all very rarely causes. Okay, dengue, malaria and all are very rare causes. So remember this much: typhoid, tularemia, okay, brucella also, okay, Legionella, Mycoplasma, Rickettsia, diphtheria and yellow fever. You remember this much, it will be enough. Okay, next, so these are the ones which are asked in your exams, entrance exams. Next is non-infectious causes, can be drug fever or factitious fever, malignant lymphoma, beta blocker use, CNS lesions. All those things will be non-infectious causes. Okay, so this was to do with rate. Rate you look for whether it is normal. If it is not normal, it can be either brady or tachy, and the respective causes you'll have to know. It was easy. Next is rhythm. How you will look at the rhythm. Normally the rhythm is regular, so every activity is regular. So what you, if you feel for the pulse, every pulse is followed by a pause, followed by one more pulse, followed by normal pause, followed by the pulse. So this is the regular activity. If there is variation in this activity, then we call that rhythm is irregular. So how can this rhythm be irregular? This can be of two types. Confusing names. One is regularly irregular. Regularly irregular means the rhythm is irregular. It is not the usual activity which you are seeing in terms of. So it is not the usual activity you are seeing. This is not the usual activity you see. That is why it is irregular. And how can this irregularity can be predictable? So predictable variation in the rhythm is called as regularly irregular. So what are the causes? One is sinus arrhythmia. Sinus arrhythmia is one with inspiration, heart rate increases. Why does this happen? Why does heart rate increase with inspiration and decrease with expiration? Anyone who knows the answer in your chat box? Okay. So one more is premature or ectopic beats which are occurring regularly. If they occur regularly, the fact that they are occurring, the rhythm is irregular. But since they are occurring regularly, you can predict the pattern of variation. Okay, that is why it is regularly irregular. Next, atrial arrhythmias with fixed block. If the block is fixed, then okay. Then partial AV block, like 2:1 block, Mobitz type 2 block. In those conditions, we can expect what the variation is going to be. Okay, so on inspiration, yeah, because of increased negative intrathoracic pressure, there will be the pulmonary vessels will take up large amount of blood. So less amount of blood will go to the left ventricle. So the left ventricle stroke volume decreases. Because of this, there will be stimulation of the baroreceptor, which will lead to increase in the heart rate. Right opposite is with expiration. Okay. Next is irregularly irregular rhythm. When do we expect an irregularly irregular rhythm? This happens when this variation, you cannot predict the variation. One is there will be irregularity, and that irregularity cannot be predicted. And classical example is atrial fibrillation. So any atrial tachycardia with variable block, you can expect this irregular rhythm. And the most common one and the classical example is atrial fibrillation. Good. So, and it's also called as delirium cordis. It's also called as delirium cordis. So this was to do with the rhythm. So next we'll see intermittent pulse. So what is intermittent pulse is, so whenever you have this atrial AV block, like 2:1 block, or when you have that atrial arrhythmia with fifth block, we will not expect So when this is okay, where was I? Okay, whenever there's a block, not all the activities from the SA node reaches the ventricle because AV node blocks them. In case of atrial arrhythmias or a partial AV block, whenever this is there. So in these cases, what happened? There will be intermittent dropping out of the beat. No, correct. No, intermittent dropping out of the beat is present. So what you'll feel, you'll get two pulses and you'll miss out one pulse. You'll get two pulses, you'll miss out one pulse when there's a 2:1 block. So that is what is called as, this dropping out of pulse is called as intermittent pulse. And when does this happen? In case of AV block, ventricular bigeminy, ventricular trigeminy and all, you expect this to happen. So next I'll draw two waveforms. Okay, so this is one waveform. One more is, okay, what is this and what is this? What is the first one? What is the second one? Will be conducted. That's why. Okay. So yeah, good. Second one is pulses alterns. First one is pulses bigeminy. Very good. So let's look into them. Next is, one is pulses bigeminy. So what happens over here is, pulses bigeminy is seen in case of ventricular premature contraction. Ventricular premature contraction. So whenever there's a premature contraction, what happens? There will be a normal beat. That normal beat is followed by a premature contraction. Between one beat and second beat, there will be a premature contraction. Okay, so because of this premature contraction, there will be decreased diastolic filling. So when this happens, there will be stroke volume will be decreased because of the premature contraction. So what happens? There will be decrease in the amplitude of that particular beat. That is followed by a pause. This is followed by a compensatory pause. Okay, before the next beat. So there will be one normal beat followed by a premature contraction, followed by a compensatory pause because of the refractory period, followed by one more normal activity. And this premature contraction amplitude is very low amplitude because of the decreased stroke volume. Okay, so that is what we see in case of pulses bigeminy. This shouldn't be confused with pulses alterns. This shouldn't be confused with pulses alterns. What is pulses alterns? There will be one high volume pulse followed by low volume pulse. High volume pulse followed by low volume pulse. Okay, you guys have not seen. Where do you expect pulses alterns? Where do you expect pulses alterns? Yes, it is not just normal left ventricular failure, severe left ventricular failure. If pulses alterns is there, we can tell that myocardium is very severely injured. So the left ventricular failure is severe. So it is one of the most specific signs we can tell. Clinically, it will become one of the most specific signs. Okay. So pulses alterns, what happens is, there is regular alteration in the size of the beats. So the beat being regularly spaced but alternatively large and small. So it is a regular activity, but one will be large volume, one will be low volume. Over here, the activity is irregular. Over here, the activity is regular because what we expect is one beat over here, one beat over here, but one premature beat comes over here. But that doesn't happen over here. There will be one large volume pulse, there will be one low volume pulse followed by regular interval. Okay, so that is important. If detected clinically, is a ominous sign of left ventricular failure. Okay, and how do you detect this? One is palpating at the carotids, but it is really difficult just by palpating at the carotids to tell whether it is pulses alterns or not. Second one is using sphygmomanometer. You raise the pressure above the systolic pressure, then slowly come down. Once you slowly come down, initially what you feel is the high volume activity. So only the large pulses that are present, that are coming, you will feel. So once you lower bit more, the pulse rate will double. The pulse rate, what is audible for you, will double. Or when you feel it also, what you feel will double. Okay, so that is how you measure using sphygmomanometer. Okay, so why does this pulses alterns take place? Again, left ventricular is severely damaged. So if we put an extra systole, for example, in a normal patient, if there's an extra systole, because there is some variation, there will be an extrasystole. So what this extrasystole will do? Because of extrasystole, the left ventricle wouldn't have contracted properly. So what happens in the next beat? Because the stroke volume is large, because the end diastolic volume is large, because of the extrasystole, the heart did not contract properly, end diastolic volume is increased. So as a result of Starling's forces, ventricle will contract more vigorously. Ventricle will contract more vigorously. So after that extrasystole, there will be a large volume pulse. So in a normal patient, that extrasystole dies out. So that activity dies out. But in case of left ventricular, where the muscle is myocardium is totally injured, it doesn't die out. So one activity, because of Starling's forces, heart will somehow pump out the blood. After that, again it will die off. Myocardium is injured, so there will be a low volume pulse. Again, end diastolic volume increases. Again, this cycle keeps repeating. Okay. So how do we differentiate? So it is easily confused. Pulses bigeminy and pulses alterans is easily confused. One, pulses bigeminy is an irregular rhythm. Regularly irregular rhythm. So rhythm is altered in case of pulses bigeminy. Pulses bigeminy is an example of irregular rhythm, ventricular premature beat. But pulses alterans, the rhythm is regular over here. Okay. Next, timing of the pulse, timing of the weak beat. Weak beat is felt closer, very closer to the preceding normal beat. Over here, they are evenly spaced because they are regular beats. Okay. So next, I had spoken about intermittent pulse, wherein you will feel the pulse being dropped out. The same thing, if there's a atrial fibrillation also, there will be drop in the pulse. Correct, no? If it is caused by atrial fibrillation also, there will be drop in the pulse. If it is because of a 2:1 AV block also, there will be drop in the pulse. How do you differentiate the two? Anyone? Yes, Ravish gave the answer. It is by the pulse deficit. So what is pulse deficit is heart rate minus the pulse rate. So in case of atrial fibrillation and all, heart rate will be there, but the pulse beat will be missed. But in case of AV block, heart rate is the heart hasn't pumped over there. So the pulse deficit won't be there. So let's see. Let's look into the pulse deficit. Over here, on doing simultaneous cardiac auscultation and palpation of the peripheral arterial pulse, so you auscultate and you do peripheral arterial pulse, you palpate. Normally, what you expect, you don't expect any deficits. So heart rate minus pulse rate will be 0. No deficit exists. So why is this used? One is it helps to differentiate between a drop beat from ventricular premature contraction or extrasystole. Over here, what happens? The heart contracts. There will be a heartbeat, but that is not continued. That is not propagated till the periphery. It is not strong enough for the pressure wave to go up till the periphery. So you will not feel the pulse rate. But in case of AV block and all, the heart doesn't contract itself. So one is we can differentiate between the two. We can differentiate between the intermittent pulse and this one, atrial fibrillation, or ventricular premature contraction, or an extrasystole. One more is exaggerated pulse deficit greater than 10 is present in cases of atrial fibrillation. So this helps to differentiate ventricular premature contraction from atrial fibrillation. In atrial fibrillation, we can expect the pulse deficit to be greater than 100 because the heart activity will be rapid. Because of the rapid activity, pulse deficit will be more. Okay. So what is the cause of this pulse deficit? Low stroke volume and low ejection velocity. Low stroke volume and low ejection velocity will result in decreased amplitude. So this won't be carried till the periphery. So next important Viva question that is asked is, how will you differentiate VPC from atrial fibrillation? One is based on pulse deficit. Over here, pulse deficit is less than 10, and atrial fibrillation, since the heart is contracting rapidly, not all gets conducted to the periphery. Stroke volume will be very less. So greater than 10 will be pulse deficit. Next is A wave on JVP. A wave on JVP, since P wave is not present, it will be absent. But over here, ventricular premature contraction, it will be present. Next one is a phenomena called as post extrasystolic pulse. So what happens over here is, in case of ventricular premature contraction, we saw that there was a compensatory pause. That waveform, yeah, we saw that there was a compensatory pause. When this compensatory pause is present, there'll be increased filling, increased diastolic filling, increased diastolic filling. So that will lead to increased end diastolic volume. When there is increased end diastolic volume, stroke volume will be high and left ventricular contraction will be vigorous. So when this happens, we can expect a surge in the pressure. So this surge in the pressure is called as post extrasystolic pulse. It is greater than 10 mm Hg, 10 mm Hg because of the compensatory pause that is present. But that won't be present in case of atrial fibrillation. There is hardly any pause. There is no place for the heart to recover itself. So that is absent. Okay. So these are the points that is used to differentiate a VPC from atrial fibrillation. This was important. Okay. So next we'll move on to the volume. So rate over, rhythm over, pulse deficit over. So let's look into the volume. So what is meant by the volume is, volume is not a measure of the waveform. Till now what we saw was the character. What we saw over here, the recording, all those things was a measure of the character of the pulse. Character of the pulse contributing to the contour, the pressure wave, reflected wave, how it affects. But what you mean by volume is the degree of the expansion of the artery. How does the artery expand? So what does that mean? There will be one at the diastole, artery will be normal. Post systole, the volume, there will be an expansion and relaxation, expansion and relaxation. So indirectly, this volume measures the pulse pressure. So it's equal to measuring the pulse pressure. Okay, it's really equal to measuring the pulse pressure, systolic pressure minus the diastolic pressure. So that is what is meant by volume. Volume is an indirect measure of pulse pressure. So it is nothing but the expansion of the artery in between the diastole and systole. Okay, displayed between the variation in the expansion of the artery present between the systole and diastole, nothing but the pulse pressure. So it can also be called as expansion or amplitude of the pressure wave. Volume or the expansion or amplitude of the pressure wave. So what will this be dependent upon? What will this be dependent upon? One is the amount of blood ejected or the stroke volume. Just like how we saw for each contour, for each wave, few things affected, few things contributed. In the same way, what will contribute to the amplitude? What will contribute to the expansion of the vessel? Obviously, the amount of blood ejected. That is nothing but the stroke volume. Two is velocity of ejection. How fast is this ejected? So both of them together contribute to momentum of ejection. Next is in the periphery, degree of peripheral resistance. Okay, if the peripheral resistance is low, diastolic pressure will be low. So you can expect a nice expansion. When the pressure is low, when the peripheral resistance is low, you can expect the expansion to take place well. So you can expect the volume, what you feel, to be hyperdynamic. Right opposite, in case the peripheral resistance is high, as in hypertension, you will be able to feel 3D pulse. You will not be able to make out the volume that well because the vessels will be stiff. So you won't expect the expansion to take place. Correct, no? So one is the normal volume. So it can be increased volume or low volume. So when do we call it as increased? That is in terms of hyperkinetic pulse or hyperdynamic pulse. So over here it is a high volume pulse. So high volume means the amount of volume ejected will be increased. So high volume pulse or high amplitude pulse, we can call it to be. So you will feel the pulse to be bounding. So you can also call it to be bounding pulse. So where do you expect? Obviously in case of increased cardiac outputs, you will expect this. So like in case of anemia, hyperthyroidism, pregnancy, Paget's disease due to AV communication, beriberi, aortic regurgitation, in all these things, you will expect this. So is there any condition with low cardiac output, still you expect getting a hyperkinetic or hyperdynamic pulse? Is that possible? We studied that there are increased cardiac output states. Okay, let me tell it is because of complete heart block. But why in case of complete heart block you get that cardiac output is reduced, so you expect the volume to be reduced now? Why do you still get a hyperdynamic pulse? How come mitral regurgitation? No, how come in mitral regurgitation? What happens? We'll talk about it later. Decreased heart rate, aortic regurgitation. No, no, no. It is because of complete heart block. It is correct. What is cardiac output? Cardiac output is stroke volume into this thing. So if stroke volume is reduced, but the heart rate is less in case of complete heart block, but the stroke volume will be more because the end diastolic volume is increased because of the Starling's force, stroke volume will be more. So even though there is less cardiac output, the because of increase in stroke volume in case of chronic complete AV block, you can expect hyperkinetic or hyperdynamic pulse. Okay. Next is hypokinetic pulse. Next is hypokinetic pulse. So in this, you expect low volume pulse or low amplitude pulse because stroke volume is less. So what is the pulse you feel? You will feel thready pulse. You will feel thready pulse. The character of the pulse, the volume of the pulse, when you palpate, you call it to be thready pulse or pulsus parvus. It's also called as pulsus parvus. This is seen in low cardiac output states, or it can also be seen in severe systemic hypertension. Similarly, hyperkinetic pulse is also seen in states of decreased diastolic blood pressure. Decreased diastolic blood pressure also it is seen, like in aortic regurgitation already mentioned, or in all these conditions you will feel, okay, you will get this thing. And similarly, in case of severe systemic hypertension, because of stiff vessels, you will feel hypokinetic pulse. That doesn't mean, do not confuse volume with the character. Still, because of severe systemic hypertension, because of increased resistance, still you will get a rapid upstroke in case of severe systemic hypertension, but the volume, the expansion will be reduced. Okay, so two things are different. Do not confuse one with other. Next one is water hammer pulse. So what is this? What is water hammer pulse? Anyone? Did you find very classical? Invariably they'll ask this, and in clinics you will be seeing one or two cases. Yes, very good in case of aortic regurgitation. So it's also called as collapsing pulse or Corrigan's pulse or dancing pulse or Watson's pulse. Okay, so what you see over here is this is a water hammer. In water hammer, what happens if you shake it like this? There will be proximal as well as distal runoff of the blood. So that is what you expect in case of aortic regurgitation also. We'll see why that happens. We'll see. So it is just nothing but exaggerated form of the same hyperdynamic pulse. It's an exaggerated form of the same hyperdynamic pulse. So what do you expect over here? You expect a rapid upstroke followed by rapid descent. Okay, so it happens in case of large stroke volume and low diastolic pressure. So because of large stroke volume, there will be a rapid upstroke. Rapid upstroke is because of large stroke volume, and there will be low diastolic pressure. So peripheral runoff of the blood will be very fast. So what you feel? A rapid descent. So rapid ascent and rapid descent. This is what you feel. Again, this is what you feel. This is volume. Don't confuse it with the contour of the pulse. Okay, character of the pulse. This is the volume, what you feel. Okay, so this happens in case of aortic regurgitation, and it's mimicus. Something like if there is an aortopulmonary window, or if there is PDA, or if there is aortic sinus rupture. In all these conditions, you can expect this. Okay, so the rapid upstroke is because of very large stroke volume, and rapid downstroke is because of proximal and distal runoff of the blood. And how do you elicit clinically? You look for it as it is by feeling for it. Also, you can see rapid upstroke and rapid downstroke. And if you want to further exaggerate the effect, you raise the hand. Yes, someone raised their hand. Very good. You raise the hand. Decrease the diastolic pressure even more, so the descent will become even more apparent. Okay, so this was to deal with the volume of the pulse. Again, volume is different from the character of the pulse which we see. Okay, so next, coming to the character of the pulse. In case of the character of the pulse, what all we study? One is you look at the contour of the pulse. One more is you look at the upstroke. Contour of the pulse, we tell that character of the pulse can be seen by looking at the carotids. Yeah, you can look at how the nature of upstroke is. And in case of certain abnormalities, you can make out. Okay, but it is better made out by keeping a gauge. By keeping a gauge, it is better made out. The contour is better made out. Okay. In case of abnormality, you can make out the character. So we'll see. One is it is seen in terms of upstroke, or other one it is seen in terms of contour. So what is seen through upstroke? Upstroke is, how do you see for upstroke? Palpatory method of assessing the rate of rise of pulse from its onset to the peak. So palpatory method of assessing the rate of rise of pulse, how fast the pulse raises. Okay. So normally what do you expect? A sharp rise and a rapid fall. Sharp, sorry, not fall, sharp and rapid upstroke is what we expect normally. Okay. So this happens when there's an unobstructed ejection from a healthy ventricle. If there is no obstruction to the flow of the vessel, then we expect this. So this gives the normal tapping sensation. What you feel for normal tapping sensation, what you feel for near the carotids is nothing but this. So, but what happens when there is certain abnormalities? One is there is significant obstruction. This happens in case of aortic stenosis. Over here, what happens is, because of the blockage, there will be upstroke will be delayed. No, there will be slow race. There will be, you tend to have a slow race. You can't have a rapid upstroke because it is delayed. There is some amount of obstruction present. So obstruction will be delayed due to obstruction. So this will lead to slow race and sustained gentle type of pushing sensation. So that will lead to something called like thrill or shudder sensation is what you feel. And what is the contour you will get in that case? You will get what is called as pulsus parvus et tardus. So what is it? Parvus means slow ascending limb. Because of the obstruction, there will be slow ascending limb. So slow ascending limb. Next is et tardus. The normal activity you will expect is something like this, but over here it is smaller. It is smaller, no? So pulsus parvus et smaller tardus. Tardus is late, poorly defined peak. The peak what you get is poorly defined and it arrives much later. Over here it has arrived over here, but over here it arrives much later, again because of the obstruction which is present. Okay, along with the low amplitude pulse. If you look for volume, it will be a low amplitude pulse. Again, see, this is normal. Over here amplitude is reduced. Okay, so, and in certain conditions of severe aortic stenosis, you can expect a brachioradial delay. Obviously, because the pulse wave that is generated is very slow. Pulse wave that is generated is very slow in case of aortic stenosis. So it reaches the radial much later than brachial artery. So you can expect brachioradial delay because of severe, in case of very severe cases of aortic stenosis. So next question is it possible to have normal waveform with aortic stenosis? Is this possible? If possible, when does this happen? Someone tells concomitant TR. Any other answer? Yes. Shreya, very good. Shreya got the answer. It happens in cases of severe hypertension. Severe hypertension, what we read was, in case of severe hypertension, what we had read, there will be the peripheral resistance will be very high. That will lead to stiffness, increased stiffness of the vessel will be there. When the vessel is so stiff, what you expect? You expect a rapid upstroke. You expect a rapid upstroke. So even in the presence of severe, in the presence of aortic stenosis, if there is severe hypertension is present, that will, this hypertension will override the effect of severe aortic stenosis and you will get a normal waveform. Okay. So that is the reason. So rapid upstroke you will find in case of hyperdynamic circulation, already discussed. Okay. So When will you find rapid upstroke with low amplitude pulse? So from that time, I've been telling character is different and amplitude is different, correct? No, amplitude volume is the expansile nature. Character is the waveform that is produced because of the pressure wave activity. So when you will expect, so till now what we read was, if there is a rapid upstroke, there will be hyperdynamic circulation. So you will expect the volume also to be increased. But when does this happen? Rapid upstroke with low amplitude pulse. Anyone with the answer? Two conditions are there actually where you expect this. When does this happen? Actually, one of you answered that question. Gave the answer for something else. It was for this actually. One of you had given. Yes, Krishna Reddy and 1 plus. Very good. It is in case of Hawcom and in case of AR with MS. AR with MR. AR with MR. In this and this, we expect rapid upstroke along with low amplitude pulse. Okay. Why rapid upstroke? Because in both these things, stroke volume will be raised. Stroke volume will be raised. So there will be rapid upstroke. By low amplitude you will get, because in case of Hawcom, there will be systolic anterior movement of the mitral valve. SAM will be there. So in this presence, in the mid of the systole, you will expect a decrease in the amplitude. There will be hindrance to the flow. So that is why there, even though there is rapid upstroke, there will be low amplitude. In case of AR with MR, so there will be runoff of the blood through the regurgitant mitral valve to the left atrium. Some amount of blood goes. That's why you expect low amplitude. Okay. So this was the cause. Next, in case of character, we read that one is you look for upstroke. Second is you look for contour. Correct, no? So what all you will see in case of contour? So normal arterial pulse, if you want to judge an arterial pulse based on palpation, you are expected to find a single impulse with each cardiac systole. So volume, you look for expansion. So you will see bounding, 3D pulse, all those things. If you are going to check for contour, you will look for impulse, the number of impulses that come. So normally one is you look how the upstroke is. Second one, you look for the impulse. Normally you will just feel single impulse. If you put a gauge, then you will get the normal percussion, tidal, dichotic wave, all those things. But if you want to palpate, you will get a single pulse. So that is how you look for the contour. So next we'll come to the abnormalities. Okay. So one is pulsus bisferens. So do not confuse. This is pulsus bisferens. Don't confuse this with the pulsus bigemini. This is pulsus bisferens. Over here there will be two systolic peaks. Bigemini was different. Pulsus bisferens is abnormal contour, abnormal character of the pulse. Okay. So yeah, and again, this can be asked in your viva. Carotid is the best site for palpation, no doubt, to elicit pulsus bisferens, but radial artery is usually used because in case of aortic regurgitation and with aortic stenosis, you will expect brewing to be present in the area of carotid. So that time you might not be able to elicit this. So you'll go and measure radial. You'll go and look for radial in that case. So when do you expect pulsus bisferens? One is either severe AR has to be present or AR with AS has to be present and Hawcom. So which among this is what? So I've shown you two pulse, carotid pulse tracing. Okay. Which is Hawcom, which is AR with AS. This is A, this is B. Which is AR with AS and which is Hawcom. Okay, 1 plus has given it, right? But 1 plus, why did you say so? How did you tell? Why is this AR with AS and why is this Hawcom? Yes. Looking at the T wave. Good. So you guys are aware of it. So let's see. One, why do we get pulses bisference? We'll look at it now. So in case of severe AR, what happens? Systole between S1 to S2, there are three phases, of which one is isovolumetric contraction. In severe AR, the end diastolic volume will be so much that you will expect two systolic peaks, because the isovolumetric contraction itself should be so good that you will expect two systolic peaks. That is in case of severe AR. When there is AR with AS, what you expect is AR will lead to high stroke volume, correct? No, that will lead to a very high amplitude wave. Next, AS will lead to high velocity of the jet. The blood that is ejected comes with very high velocity. And according to Bernoulli's principle, it states that whenever there is such high velocity of blood, lateral pressure will be inversely proportional to the velocity of the flow through the tube. So there is percussion wave, there is tidal wave. Okay, so when this happens, one, because of high amplitude wave, you will get a good percussion wave. Then because of Bernoulli's pressure principle, because of the high velocity of the jet of the blood, there will be a sudden dip in the lateral pressure because of aortic stenosis. So you see over here, there will be percussion wave. Then because of the dip in the lateral pressure, because of Bernoulli's principle, secondary to aortic stenosis, there will be a dip in the pressure, followed by a nice tidal wave. Because large volume of blood will still be left in the aortic regurgitation, so the contraction will be usually in the first 1/3 of the systole only. Almost all the blood, because of active contraction, goes up. But because of aortic regurgitation, the end diastolic volume will be so good that stroke volume will be very high. So there will be a very good tidal wave activity, followed by this dip in the pressure. Okay, but what happens in Hockham? There is the reason why bisference happens is different. That is why there is difference in the nature of the wave. In Hockham, what happens is, due to systolic anterior movement of the mitral leaflet, what happens is, this happens in the mid systole. When this happens, suddenly there will be obstruction to the blood. This leads to sudden dip in the pressure. This is followed by resumption of the activity in the late systole. But again, since Hockham, there will be hypertrophied ventricle, most of the blood is ejected in the initial 1/3 of the systole only. So the next late systolic peak, what you see is a much smaller one. So the percussion wave will be larger, followed by a small peak in the late systole. Okay, that is followed by a dichotic wave. Okay, so this is what we see in pulses bisference. So the two causes, and both the causes are due to different reasons. And this type of pulse is called as jerky pulse. This type of pulse is called as jerky pulse. Okay, because you will find two activities in the systole. One very good high volume activity, one more is a small low volume activity. That's why it is called as jerky pulse. Anyone know what this sign is? Brockenbrough sign. What is this? If you guys do very well in your Viva, they might ask this. Anyone knows what this Brockenbrough sign is? It is seen in Hockham. I put it under Hockham only. That's why. Now, why does this happen? Yes, correct. Due to post extrasystole. This we had read in VPC. We had read in ventricular premature contraction. Same thing happens in Hockham. Hockham also, you can expect a ventricular premature contraction because of the hypertrophic ventricle. That itself will lead to an extrasystolic activity. So when that happens, there won't be post extrasystolic pulse. Why? Again, because of the systolic anterior movement of the mitral leaflet, it won't let that extrasystolic pulse to take place. That is what we call as Brockenbrough sign. If Hockham results in VPC, then you don't see that post extrasystolic pulse wave activity. Okay, so good. Next is the dichotic pulse. So one abnormality was the pulses bisference. In this, what we found was both the activities was within the systole itself. What is dichotic pulse? In this, you will see one activity in the systole followed by another very good activity in the diastole also. So when we palpate, you confirm it with the heart on auscultation, you'll get that there will be two activities, one activity in the systole, one activity in the diastole. Okay, so decreased cardiac output. This happens when there is decrease in cardiac output states like severe left ventricular failure, shock, tamponade, and all. And why do we get this? We'll see. Because in systole, what happens? There will be decreased stroke volume. When there is decreased stroke volume, left ventricular ejection time decreases. One more is because of that there will be decrease in left ventricular contraction also, because there will be LV failure and all. So this will lead to what? Momentum of ejection will be low. So all these things will contribute to a very slow percussion wave. So a very small systolic peak we expect, followed by what happens in the diastole. What happens? There will be increased peripheral resistance and vasoconstriction. So when this happens, the reflected wave what you see will be good. So intensified reflected wave will be there. So that will lead to one more diastolic peak. So this is what we see. We see a systolic peak and a diastolic peak. Systolic peak and a diastolic peak. Systolic peak followed by a diastolic peak. So this was dichotic waves. So now next is, both are normal, but can you differentiate which waveform is from a young person, which waveform is from a old person, A and B? A is okay. Why do you guys say so? Why do you guys say so? Tidal wave is high. Yes, good. Why? Why does this happen? Yes, correct. Good. Again, as we progress, as old age comes, there will be increase in the stiffness of the vessel. Increase in the stiffness will lead to increased peripheral resistance. When that happens, the reflected wave which is there is very good. And when the mean arterial pressure increases because of peripheral resistance, when the mean arterial pressure increases, the velocity with which it is reflected, one is intensity is good. Two, when there is such stiff vessels, the velocity with which it comes back also is good. Even if you strengthen a wire and press in between, you will see that more you strengthen, the more faster it will come and hit your fingers at the end. Correct, no? So the reflected wave that comes back, one, it comes back with very good intensity. Two, it comes back much faster. So usually what you expect the reflected wave to come in the diastolic and give a diastolic peak as dichotic wave. But what happens over here is it comes much before. It comes in your late systole itself, and it will increase your central aortic pressure, okay, which will lead to increase in the tidal wave. So percussion wave followed by increased tidal wave and the dichotic wave. So they might ask you in your entrance exam, which is the pulse waveform from a young and old, and this is how you differentiate. So this was the concept behind that. Next is the tension. So what they mean by tension is, it is not the tension which we learned earlier in the session. That tension was different. That tension was what you measure through the gauge. This is different. This over here they mean the basal diastolic tone. This is by palpatory what you see. So corresponds to the basal diastolic tone of the blood vessel. Nothing but the diastolic blood pressure. Why will there be decrease in peripheral? There won't be decrease in peripheral resistance in dichotic pulse. It's just that the dichotic pulse, which is expected to come in the diastole, comes much earlier because of the reflected wave activity. So that is why the activity that was supposed to happen over here happens over here only. That will lead to accentuation of the tidal wave activity, followed by a dichotic wave, followed by whatever is left, whatever wave that is left from the extreme periphery, whatever that comes will lead to a small dichotic wave activity. There won't be decrease in the peripheral resistance. Peripheral resistance remains the same. Okay. In dichotic pulse, there is increase in peripheral resistance. No, I never mentioned there is decrease. When there is such shock taking place, peripheral resistance will be increased so that the central supply will become more. Increased peripheral resistance has been mentioned. So tension is basic diastolic tone of the blood vessel we measure. How? There are two ways. One is we look at the state of the artery in between the pulse beat and see whether it is soft in nature or hard in nature. If it is hard in nature, there is high tension pulse. If it is soft in nature, it is a low tension pulse. So we call it as pulsus mollis in case of low tension and pulsus durus in case of high tension. Next is you palpate the pulse with light, medium, and heavy pressure. If you are able to feel with light pressure, then it is low tension, medium is normal activity, and heavy pressure, it is a high tension pulse. Okay, so this is how we make out. Next is the delay. So coming to this final two components, one is the delay. So normal delay, what you expect is from the carotid as we move towards periphery, if in MCQ, if it is asked, if 40 and 30 milliseconds both are asked, go for 40 or else go for 30. Okay, so 40 milliseconds followed by brachial 60 milliseconds, femoral is 75, radial is 80. So this is important for the MCQ. They will ask. So because standard textbooks mention 40, Alagappan has mentioned 30. So, but it is important to remember. They'll ask in your YO also, they'll ask in your entrance exam also, they'll ask. Okay. Soft means the tension is low. The basal tone, the basal diastolic tone is low. High means it is high. In case of old age and on, because of increased diastolic tone, increased peripheral resistance, they will find a hard coil-like nature. Soft means in younger person, you'll feel it to be soft. So when do you expect a delay? We expect delay in case of coarctation of aorta. There are other conditions like aortic dissection and all. We'll not read about that in detail. We'll see the basic is because of coarctation aorta, and depending on the location where it is, we'll get either a radiofemoral delay when it is over here, when the site of obstruction is distal to the left subclavian artery, this being the most common. And if it is proximal to the left subclavian, you will get a radial delay. So if it is over here, then you expect a radiofemoral delay. If it is over here, then you get a radial delay, or you get a right-sided radio and femoral delay, right-sided radiofemoral delay or a radial delay. Okay. So next is coming to the condition of the blood vessel. How do you measure? One is with the ring finger, you occlude the blood vessel. Then with the index finger, you move out the column of the blood by pushing it behind, and then with the middle finger, you look for the condition of the vessel wall. So hope you know how to elicit the method. And if it is palpable, then the vessel is atherosclerotic. That's all to do with the condition. Then coming to the final one being the pulsus paradoxus. Okay, so this is very important. Normally what happens during the systolic blood pressure, during inspiration, systolic blood pressure is expected to decrease up to 10 mmHg, less than the systolic blood pressure during expiration. Why does this happen again? Because of the greater intrathoracic pressure, greater negative intrathoracic pressure during the inspiration, left ventricular filling will decrease. That's why it is expected to decrease. But if this decrease is more, if it is more than 10 mmHg, then you call it to be pulsus paradoxus. Then you call it as pulsus paradoxus. So normally during inspiration, what happens? Right ventricular blood flow will be more. Right ventricular blood flow will be more, and left ventricular blood flow decreases. So when right ventricular blood flow is low, how does the right ventricle accommodate? Its lateral free wall expands. And this is how it accommodates. Okay. So now what are the causes of pulsus paradoxus? We'll see. One of the cardiac cause, most common being cardiac tamponade. Most common form is cardiac tamponade. In cardiac tamponade, what happens? There is compression of the heart by the pericardial fluid. So during inspiration, when the right ventricular filling is more, the right side free wall cannot expand. Right side free wall cannot expand because pericardial fluid is there. It is hindering the expansion. So what happens? The interventricular septum will bulge into the left ventricle. So as it is in the left ventricle, there is decreased filling, and there is this bulge also. It will lead to even more lesser filling. So this will become the inspiratory dip in the systolic blood pressure will increase even more. So that will lead to pulsus paradoxus. Okay, yeah, bowing of the interventricular septum. Good. Next, one more cause is constrictive pericarditis. This happens in almost 1/3 of the cases. Over here, what happens? There is failure of relaxation of the heart because of the stiff pericardium. In constrictive pericarditis, there will be stiff pericardium. So in severe cases, like in almost 1/3 of the cases, what happens again during inspiration, right ventricular blood flow will be more, but the free wall will not expand. What happens again? There will be bowing of the interventricular septum. The same reason. Okay. Now coming to the non-serious cause. One is acute exacerbation of COPD or asthma. This being the overall, this is the most common cause for pulses paradoxes. In this, what happens? Two causes. One is lungs are hyperinflated. Because of this, there will be increased cooling in the lungs. So there will be decreased blood going into the left ventricle. As it is going less in the inspiration. It becomes even more in case of acute exacerbation. One more is, when there is acute exacerbation, the patient will have take deep inspiration. The patient will be gasping. So inspiration will be deep. When this happens, intrathoracic pressure will be even more negative. When this happens, venous return will be even more. So there will be maximum dilatation of the right ventricular free wall. After that, what happens? Again, some amount of bowing of the interventricular septum takes place to accommodate the extra blood. So that will again lead to decrease in the left ventricular volume. So this is the reason. Next is obstruction of superior vena cava. When this happens, there is decreased venous return to the heart itself. That can be one of the cause. One more is pulmonary embolism, again because of increased pulmonary pooling of blood. Then in case of severe obesity, hypovolemic shock and all, we expect. And they won't ask this question because the mechanics of this is very complex. But in case if they ask in your viva, where do you see reversed pulses paradoxes, then you see in case of Hockham and intermittent positive pressure ventilation. The mechanics is very complex, so don't bother about it, and they'll not ask also. In case they ask, then know that it is Hockham and IPPV. So that's it with today's class. So any doubts you can ask. So this is what you should know. The pulse means it's a regular MCQ question as well as your viva question. Very, very important. So when you examine in all the aspects, and know some amount of basics, know how to examine. That is very, very important. Know how to examine, and followed by what are the components. Shreya, what's the paradox? Reverse pulses paradox. You want full pulses paradoxes or the last one? Last one is nothing but where you see reverse pulses paradoxes. You usually systolic blood pressure decreases, but over there systolic blood pressure will increase during inspiration. That is seen in Hockham and IPPV. Rapid downstroke is there will be peripheral runoff of the blood because diastolic pressure will be very low. Blood pressure will be low. When diastolic blood pressure will be low, there will be vasodilatation. So pressure dip is more. From high pressure to low pressure area, there will be peripheral runoff of the blood. That is responsible for rapid downstroke. And that is one of the cause. And there will be regurgitant blood flow going back also. There will be regurgitant blood flow going back into the left ventricle also. So both these things together will cause rapid downstroke. What is meant as Redmi? I didn't get your doubt. So rapid upstroke, is it necessary that only AR is also possible for rapid upstroke? That is AR and MR. Rapid upstroke with low amplitude is AR and MR, because there will be blood will run off to LA. Because of that, amplitude will decrease. Okay. I didn't understand Redmi 7. I didn't get your doubt. Could you please repeat? Anyone else? Any other doubts? Please explain how come. In what how come? Where did it go? See, in Hockham, what happens is there will be ventricular hypertrophy because of irregular ventricular hypertrophy. Because of that, what we expect, left ventricle contracts vigorously. Okay, because of that, you expect rapid upstroke. That is one thing in Hockham. But one more thing, what happens is in the middle of systole, there will be the mitral valve, anterior mitral valve that is there, that will come in position of the left ventricular outflow. Okay, the dynamics is such that in HOCM that happens. There will be systolic anterior movement of the mitral valve leaflet that will obstruct the flow of the blood. So what do we expect is the pulses bisference. Is it seen now? Yeah. So the pulses bisference, why it happens? Pulses bisference is two systolic activity, percussion wave and tidal wave. Both the systolic activity you will feel. Usually you see only one, but in pulses bisference you will see two peaks. So why does that happen? In case of HOCM is one, because of good upstroke there will be a nice percussion wave. Okay, in the pressure because of the because of the systole SAM, because of SAM there will be sudden dip in the pressure. This is followed by again usual ventricular contraction. The SAM, the mitral valve that is there, that will move away. Okay, so there will be again a late systolic peak. That is what we see in HOCM. Okay. To palpate carotid, yeah, you use thumb only. Thumb is better than 3 fingers to palpate carotid. Okay. In carotid, only one peak. That is what I've been saying. That is the whole thing. Contour abnormalities, when you look for the character of the pulse, normal arterial pulse on palpation is a single impulse. What we read initially as the percussion, tidal and dichotic wave, that you see on keeping a gauge through manometer reading, you'll feel that. But on palpation, you'll get only a single impulse in carotid pulse. Okay. So I was asked what's the function of the 3 fingers, not just in condition of vessel wall, but for other components. Okay. Okay, even I am not aware of it. Might be that one finger will not be able to see the fluctuation in the pulse, so you will see 3 to get your reading much more perfect. Even I am not that aware. Okay. For clearing of blood, that is in case of condition, but other than condition she was asked. So I think that so that your reading becomes much more perfect, but even I am not aware of that. I will find that out. Okay. Any other doubts on YouTube if it's there? Okay, on YouTube there is not many doubts. So if you guys have any other doubts, so I've given my mail ID as well as my phone number. You guys can contact. Okay, you guys can contact me through this on WhatsApp or through my email ID. So yes, we can end the class. So thank you guys. Okay, bye bye. And a very important session, though it is not being used clinically that much nowadays. To pass your exams, this is the most important topic. Okay, so please go through it once again, the video as well as the notes. The notes will be sent in a while. Okay, so bye bye.